Sorry about that. Lots of different factors come into play in terms of leading to obesity. Some of the biggest ones are genetics, uh, behavioral factors, certainly have a lot to do with it as well, in terms of like binge eating or comfort eating. There's certainly some cultural factors that influence as well as some socioeconomic factors. You'll see among minority populations, we tend to see an increased incidence of obesity. Part of that is probably due to socioeconomic factors. If you have any experience with government food assistance programs, they tend to not provide you with the healthiest of foods. And the other part of that is if you look at like spending cards as opposed to direct food provision, a lot of times those spending cards don't have any limitations, so they get spent on probably less than nutritious food because the less nutritious food can go on the shelf. It lasts longer. It's easier for folks to keep up with. So unfortunately, that tends to contribute to it. Genetics is a huge pathway, and we're just slowly starting to understand that. And then metabolic factors and activity are obviously another factor in. Unfortunately, there tends to be a lack of education, especially in kind of poorer socioeconomic groups, as far as what causes obesity, and then the long-term complications associated with it. You need to be able to calculate BMI. Um, BMI will be on this test, it will be on your boards, and then you also need to know kind of the categories that patients' weights fall into. So underweight, BMI less than 18 and a half, normal 18 and a half to 25, overweight 25 to 30, obese 30 and above. And there is actually suggestion for a super obese or a morbidly obese that's above 40. But that's not kind of standard at this point, but you may hear patients referred to as super obese or morbidly obese, and that's when we start thinking about things. Just an interesting fact for you, BMI actually came from insurance companies, so it misses some important things that may account for other body habitus. For instance, it doesn't differentiate between fat and muscle. So you can have somebody that's ripped, but because it purely takes height and weight into account, it may not account for it. Other factors that may be a little bit more specific are looking at like waist to hip or neck to waist ratios, waist circumference, those sorts of things. And then age, because as we age, we tend to see a loss of muscle mass. So you may actually have folks that are artificially more obese than we realize because they've lost a fair bit of that muscle mass. So two common distributions we see, android obesity, which is kind of central or truncal obesity. These are commonly the folks that we see that have cardiovascular disease, diabetes, increased oxygen consumption, pulmonary problems, hypertension, all those sorts of kind of comorbidities we associate with obesity. Gynecoid obesity is more of like peripheral, so we tend to see it like in legs, hips, butts, a lot of the lower extremities. Some of these folks, if you look at them, they almost look like two different bodies put together, other than the fact that their arms will also be obese. So generally, their core is not large, but their extremities are. These folks tend to be a little bit less metabolically active. The nice thing about this is that it tends not to be associated with cardiovascular disease. So the cardiac system and obesity, there are some complications and things we consider. One of the big ones is that the total blood volume is increased, which makes sense because even though it's adipose tissue, it still has to be perfused. So you're going to have increased volume. So when you start thinking about medications, some of them are dosed on lean body weight, some of them are dosed on actual body weight. There's not really good agreement as far as what you dose where, but we will talk about that um, when we get a little bit further along. As a result of that large adipose content, a lot of that volume is actually distributed there. So that can be problematic for you when you start thinking about things like vasoconstriction, because the vasculature in that adipose tissue doesn't contract nearly as well as it does in the core or in the traditional system. So that can be problematic for you. There's an increase in cardiac output, which just makes sense when you think about the larger volume of distribution. Other things that you tend to see in these patients because of that larger body habit is the left ventricle tends to be very dilated. You have a larger stroke volume initially, And then as their hypertension worsens, you tend to see that they develop a little bit of concentric hypertrophy that can be problematic for you. From a cardiovascular standpoint, you also tend to see that they're at increased risk of dysrhythmias. Some of these are true dysrhythmias, some of these are kind of more monitoring impairments. So, because of their large body habitus, they're at increased risk for embolic events. So, you'll tend to see more incidents of PEs, DVTs, and then coronary occlusion. Because of the increase in body habitus, you tend to see that there's a decrease in QRS voltage because there's physically more tissue between where you're monitoring and the heart itself. So you may have decreased voltage. Usually you can just increase your gain a little bit and kind of compensate for that. You also, as I said, have a little bit of a left axis deviation as well as left ventricular hypertrophy, especially as their disease process progresses. Hematologically, just kind of what I touched on here, you tend to have a hypercoagulable state. So they tend to have increased incidence of clotting due to factor VIII and von Willebrand's. They also have a little bit of endothelial dysfunction. So it's not surprising that a lot of these patients tend to be on some sort of anticoagulant, maybe something as simple as like baby aspirin starting off. But as time progresses, you'll see that they commonly transition to a little bit longer lasting medications or kind of more targeted medications, especially in the setting of cardiovascular, cerebrovascular disease, which is fairly common in these populations. From a GI standpoint, it's kind of a perfect setup for them to aspirate for us. They tend to have delayed gastric emptying. The volume tends to be increased, the pH tends to be decreased. So all three of those things that can be problematic for us as far as setting them up for an aspiration pneumonitis. I'll give you, for instance, last night I had a patient that BMI was about 45. She had had a procedure done the night before. Pre-procedure as well as during induction, she vomited. It did not appear to aspirate. They had done an RSI anyways, considering the fact that it was an emergent case for her first procedure. So maybe that prevented the aspiration. But for these folks, you may think about giving them pre-meds. Generally, we don't use Bicitra for non-obstetric patients, but that may be something to consider if they're very high risk. Other things to think about, giving them something like metoclopramide early may be beneficial. You just have to be really cautious about giving metoclopramide to fully conscious patients. Push it very slowly, and you can still kind of have weird effects, but it does tend to encourage that gastric emptying. So those are two things. You can also consider putting in a nasogastric tube if they're very high risk for aspiration. But that can be a double-edged sword because when you put it in there, you are going to open up that gastric sphincter just a little bit, so you can have some leakage at that point. So you kind of have trade-offs there as far as different approaches, but I would certainly consider doing something different for these folks. Other things you'll see, hepatic function tends to be a little bit impaired. So drug metabolism is altered. So not only do you have a different volume of distribution, the metabolism tends to be a little bit slower. So that can be problematic for you as well. A large number of these patients already have some sort of increased relaxation of the lower esophageal sphincter, and then they also often will be diagnosed with hiatal hernia. So both of those increase their risk of regurgitation and aspiration. From a kidney standpoint, you tend to have kind of a hyperfiltration state, which is interesting because it seems like their kidneys would be impaired, but the impairment takes a little bit longer to happen. So what you'll see is early on in obesity, their kidneys work a little bit faster. They tend to urinate more. But as time progresses, their hypertension gets worse. You'll notice that their GFR drops off pretty significantly. Other things to think about, they have increased renal tubular absorption. So their renin-angiotensin system tends to be activated a little bit more actively than a non-obese patient. And then you also have impaired natriuresis, which can be problematic for them as well. From an endocrine standpoint, you tend to have an increased level of sympathetic activity. So they have an increased level of insulin resistance, which kind of goes hand in hand with their pathway to diabetes, coupled with their metabolic syndrome. So glucose isn't metabolized nearly as well. You also have an increased pressure activity of norepinephrine and angiotensin II, which makes a little bit of sense because we were talking about the increased renin-angiotensin activity. They retain sodium more. This tends to contribute to their hypertension as well as their poor diet. And then they tend to have an increased incidence of resistance to thyroid hormones. Now, what you'll see is that there's hypothyroidism in about 25% of morbidly obese patients. It's very important for us to go back and look at their history and figure out if they have significantly increased their weight recently or if this has been a gradual progression for them. Because the initial diagnosis of hypo or hyperthyroidism may came from kind of semi-acute weight loss or weight increase changes. So when we go back and look, sometimes as soon as we get their thyroid regulated, they're able to go back to a normal body weight. These are kind of the common comorbidities we see in these patients. Type 2 diabetes is very common, as is metabolic syndrome, and we'll kind of talk about some of the differentiations for those in just a second. Because of the increased body habitus, we see an elevated incidence of obstructive sleep apnea. Asthma is common. Generally, it breaks down into kind of two categories, whether it's an exercise-induced reactive airway disease, or they also tend to have an increased sensitivity to allergies. I think in a lot of these patients, their airways and their pulmonary system is almost always in a state of inflammation, so that contributes to it as well. COPD is common. Oftentimes, and it's dropping off I said, as smoking is decreasing, but you'll see a lot of times these patients also smoke, which contributes to their COPD. Hypertension and diabetes are both extremely common in this population, so hypertension is no surprise. Tends to lead or be associated with cardiovascular disease, and then you also see that there's an increased incidence of cancer. Some of that comes down to environmental factors, some of it comes down to diet. Socioeconomic factors certainly come into play as well. You can't get the healthy food, you're doing more high risk occupations, those sorts of things. And then the increased body habitus also contributes to osteoarthritis. In fact, when you start talking about joint replacements, a lot of these patients will have to wait until after they've been able to get their BMI down significantly to be able to have treatment done. So, metabolic syndrome is kind of a newer term for prediabetes, and you may see them used interchangeably. Um, these are kind of the common factors you see, and usually we look for at least three of them to diagnose the patient with metabolic syndrome. But abdominal or truncal obesity, decreased levels of HDL, increased level of triglycerides, hyperinsulinemia, intolerance to glucose, hypertension, pro-inflammatory state, and prothrombotic state. The ones I starred there for you are the most common ones we see. Um, just be cautious with it because a lot of times we don't figure out this is what's going on until you have a patient that presents with kind of an out of control diabetic or pre-diabetic state. A lot of these patients are healthy in their own minds because they don't go to the doctor, and then something happens and they go in and they're like, "Oh, you're diabetic, you're pre-diabetic." Some of them are even on like oral diabetic medications like metformin and have no clue why they're taking it. They're not monitoring their blood glucose. So part of that, I think, goes back to us as healthcare providers for not educating our patients very well. Again, consider these patients. Most of them are not the smartest, so it may take a little bit more education on our part to kind of convey that to them. Other things, as I mentioned, waist circumference or waist to neck or waist to hip ratio tends to be a little bit better indicator of obesity for patients than BMI because some of the factors we talked about. Increased risk factors for these patients developing metabolic syndrome. Increased age makes sense, whether it's due to sedentary lifestyle, a history of poor decisions. As we get a little bit older, we tend to be less active, that may contribute to things. Men tend to be affected more than women. And as I said, minorities tend to be affected more than Caucasians, particularly Hispanics and South Asians. If you're doing clinicals in the Valley or California, I'm sure you see quite a bit of this because of the increased Hispanic population. I think it feels like almost everybody we deal with in those areas has hypertension and diabetes. Not that it's limited to that, but I think they tend to see more of those populations. Other things that can cause this that are not necessarily those factors we discussed earlier, long-term use of corticosteroids can contribute to this. Antidepressants can cause significant weight changes, not necessarily obesity. Sometimes you will see that they cause weight loss. But if you have patients that may modify their kind of dosing regimen or self-medicate, take themselves on and off their antidepressants, that can cause weight gain or weight loss as well. Same thing with antipsychotics. A lot of times those medications kind of make them either overeat or eat. It may also be associated with their underlying disease process and not so much the medications themselves. There's a significant amount of the population that kind of comfort eats, so to help with their depression or whatever issue they're dealing with, they control the things they can, and part of that may be eating. Why do we worry about metabolic syndrome? Increased risk of all the things we talked about: cardiovascular disease, type 2 diabetes, polycystic ovarian syndrome, fatty liver disease, and improper immune response. Another thing we see that's kind of interesting, and it ties back into a lot of that sympathetic stimulation we were talking about. Sometimes these patients have unopposed sympathetic stimulation, and other things that we'll see that kind of go right along with that: chronic pain syndromes, PTSD. You'll see a lot of like the COVID symptoms tend to persist in these patients. So part of the reason I bring that up is because they may benefit from something simple, like a stellate ganglion block, a beta block, or some of those sorts of things that help kind of block out some of that sympathetic stimulation. If these patients are able to change their diet or have a bariatric procedure or utilize something like GLP-1s, a significant amount of these symptoms will resolve. I can't tell you how many patients I've seen that have gone in and have bariatric surgery and then they're no longer on their meds. They don't have hypertension anymore. Their A1C normalizes. So those can kind of be very significant modifications for those patients. One thing we do have to consider is just because they have lost all the weight doesn't mean all the damage has been undone. So if you had somebody that, say, had occluded coronaries or partially occluded coronaries, the fact that they've lost that weight may eliminate some of those risk factors or comorbidities, but it's not going to go through and magically clean out their coronaries. So be cautious with those patients, even if they appear to be kind of healed on the outside. Differentiating obstructive sleep apnea and hypopnea syndrome. So obstructive sleep apnea is complete cessation of breathing that lasts 10 seconds or longer and happens 5 times or more per hour. During that time period, they also have to decrease their SpO2 by about 4%. To have true diagnosis of this, the patients will go in and have sleep studies done, and we'll talk about that in just a second. Whereas hypopnea is a reduction in airflow. So sleep apnea, true cessation of breathing; hypopnea is a reduction of airflow. Now, what you will commonly see is a mix of these two. So they will obstruct and then they come back, and when they come back, they're still breathing inadequately. So they have about 15 periods of this where the airflow reduces by about 50% every hour. Same criteria as far as their saturations decreasing, but you'll commonly see these two occur together. So how do we get this diagnosis? A lot of times we can look at the patient and figure out if they have sleep apnea or hypopnea syndrome. But if not, you may have to turn to the person that's around them when they sleep, spouse, any of those sorts of things. I can tell you when I worked at the fire department, I had a partner one time, and he would always sleep on the top bunk because he was like 6'5", so he just climbed up there. But if you were underneath him in that bunk, you were not going to sleep that night, because not only would he have all these apneic periods, but he would also almost have like a little fit when he came back breathing, where he would just kind of shake himself awake. So that's part of the reason those people are chronically exhausted, because they don't sleep well. And then when they are sleeping, they're hypoxic. So just make sure you're aware of the clinical criteria of those. So this is a little bit of information about the sleep study, also known as polysomnography. So what they do is take a combination of the apneic episodes and the hypopneic episodes and divide them out by the amount of sleep time. So they'll take these folks into the hospital. They get them all wired up. Oftentimes they'll do an EEG, a pulse ox, cardiac monitoring, those sorts of things, and they will track them for the night. The downside for the patients, I'm not sure about you guys, but I feel like it's really hard to go someplace and sleep anyways, especially like the first night. And now you know somebody's watching you. You're hooked up to all these monitors. So I suspect the true incidence of sleep apnea is even higher than what we detect. Because if it were me, I would probably lay there awake all night, like rolling around on electrodes or like stickers on my head or something like that. Um, so these are the criteria for you as far as like mild, moderate, and severe sleep apnea. You may see that again. That's kind of a common thing that pops up when we're pre-oping patients is they'll want to know how severe the sleep apnea is. Some patients know, some patients don't. You may have access to their sleep study if it was done in your facility. So how do we treat these patients? Um, so as far as the sleep apnea itself, the kind of go-to treatment is CPAP or weight loss. Just an interesting fact for you, even though we always consider these being obese patients, there are plenty of skinny people out there with no other comorbidities that also have um, sleep apnea. So don't assume just because they're skinny that they don't have an increased risk of airway obstruction. So big risks that go along with patients that do have sleep apnea, systemic as well as pulmonary hypertension, left ventricular hypertrophy, cognitive dysrhythmias, or excuse me, cardiac dysrhythmias and cognitive impairment. Um, as weird as it sounds, one of the most common places in the hospital to work codes is the sleep lab. So when you go someplace new, make sure you know where the sleep lab is because it tends to be tucked away in some random corner of the room. The good news is all these patients are being constantly monitored. The downside is all the patients are there for a reason. Usually it's because they have all these comorbidities and everything else. So there are periods where, they'll just brady out. They may obstruct to the point where they become hypoxic. So just something to pay attention to there. And then the other thing to remember is that because of the poor rest, the continuous and chronic fatigue, they tend to have cognitive impairment. Sometimes that resolves after the weight loss or after symptoms improve. Sometimes it does not. But you'll see as far as like the short-term stuff that when they start using their CPAP, that they're restful. They tend to report being more clear during the day. So just something for you to think about for those patients. Obesity hypoventilation syndrome is similar but different. You may also see this referred to as Pickwickian syndrome. I know the folks that took the C this year, as well as boards, had a question talking about Pickwickian syndrome. So you may see it referred to by either name. I'll tell you the first and kind of earliest definition I ever heard of Pickwickian syndrome was people that were too fat to breathe, which is kind of sad, but kind of true. So what you see in these patients is they're morbidly obese and they have long-term obstructive sleep apnea. So it's kind of the worst case scenario for patients with sleep apnea. As a result of that, they have severe pulmonary hypertension and cor pulmonale. They tend to remain morbidly obese. Their BMI, the definition says greater than 30, but oftentimes you'll see these patients are greater than 50, if not even higher. They will have hypercapnia at baseline. So something for us to consider with these patients is that when you're doing things like waking them up, that they may wake up sooner, or they may wake up longer, depending on what you blew their CO2 down to during the case. But be mindful that you may have to run it up just a little bit higher to get them breathing again. Other things, these are the patients that tend to experience cardiovascular issues during induction, during the maintenance phase of their case, because of this severe pulmonary hypertension and cor pulmonale. So from that standpoint, a lot of times we will do extra monitoring for them. You may do things like a flow track, or sometimes we'll even put PA catheters or utilize TEs on these patients, depending on what they're having done and how severe it is. Other things to consider, they tend to be difficult airways, and you may want to consider getting a baseline ABG on these patients before they go to sleep to see where they truly live, because commonly we'll have to leave them intubated after the case just because they're really hard to get extubated, and they tend to not do very well. So we're going to kind of go back through the history of medical therapy because you will still see some of these medications pop up. Some of them are fairly benign, some are not. So phentermine was a sympathomimetic, which basically worked to decrease the appetite. It worked extremely well. Um, The downside was the FDA only approved it for 3 months. Lots of patients were taking it for long periods of time, which was problematic for us. There are some pretty significant side effects to this when you compare it to some of the other weight loss medications. Tachycardia, palpitations, hypertension. Patients became dependent on it, and you would oftentimes see that they would take excessive doses to try and accelerate their weight or kind of increase their weight loss. Um, it was originally manufactured as kind of a combo med. You may have heard of it before as fen-phen, but it was phentermine and fenfluramine. We found patients that were taking the combination of those two, in addition to the symptoms here, the tachycardia, palpitations, hypertension, started having pretty severe cardiac issues, valvular disease being one of the big ones. So it was no longer allowed to continue in that combination. But phentermine itself is still out there. We will commonly stop this for about 2 weeks pre-procedure because one of the issues we run into these patients is when we induce them, they tend to have kind of profound hypotension that doesn't respond to kind of traditional therapies. Think about something like lisinopril. You know how a lot of times you have to get either epinephrine or vasopressin or something like that for them to respond. You'll see that same thing happens with phentermine. Orlistat goes by or works by blocking the absorption of dietary fat. Um, the good news is it works very well. The downside is patients tend to have a lot of fecal issues with it. So what you'll see is that they have liquidy stools, oily spotting. They may have like pretty significant urgency. And what I mean by that is like it just hits them that they have to go to the bathroom. And then, like, before they can even get there, they've had an accident. They tend to have very loose, watery stools as well. And it causes pretty severe abdominal cramping and kind of flatulence. I don't know if you guys have ever heard the expression of never trust a fart, but it definitely applies to these patients. So if you have somebody that's taking Orlistat and it's available over the counter, just be cautious with that. Problems we tend to run into with those patients, other than what I just talked about, they will have a lot of vitamin deficiencies with long-term use, and you may see that they have vitamin K deficiency as well. So just be careful with your coag status because the PT may be kind of prolonged. There's a whole bunch of other over-the-counter herbal agents available. Some of these are kind of trends. Some of these are pretty well proven. But as far as like things that work on the lipase enzymes in the pancreas, caffeine can be used for weight loss, green tea as well. So you'll see a lot of times you get kind of the double combination from your pre-workout because most of those have caffeine in it. So not only does it add quite a bit of protein, but it also adds a little bit of caffeine that accelerates your metabolism. So there's some things out there we take that can be used just to suppress our appetite. Ginseng or ginseng gum. A lot of times you'll see people either chew that or kind of tuck it in their cheek. Ephedra. Uh, Back in the 90s and 2000s, there were a lot of ephedra-based weight loss supplements out there, and they were combined with all sorts of weird things. Some of those have been pulled from the market because they contain the ephedra. So then they just started looking for something that wasn't ephedra but got you the same results. So you may still encounter some of those patients out there as well. Sunflower oil works, I believe, nearly the same way that the Orlistat does, but it's also a little bit healthier oil for you as far as cooking things. There's some stuff out there you can use to kind of energize yourself. Acai berry is one of them, and then caffeine as well. The downside is you tend to have crashes from both of those at some point. And then there's some other stuff out there that kind of helps regulate and reduce the absorption of lipids. But using soybean or soybean oil, fish oil, there's a lot of folks that take fish oil pills. So that helps out quite a bit. And then there's some teas out there that people swear by. Obviously, we haven't found the magic bullet over the counter. Everybody would be talking about it. But if you look, there's a lot of essential oils and kind of things like that that people encourage. And there's definitely some ability of utilizing your diet to kind of help out as far as regulating your weight. So we're going to talk a little bit about the GLP-1s, and this is definitely one of the biggest areas that we see that's kind of changing as we're going forward as far as like weight loss management and those sorts of things. But they're FDA approved for diabetic patients, and those with cardiovascular disease. Um, Now that's FDA approved. With that being said, I think everybody and their brother has figured out a way to get GLP-1s from someone. So they can be bought, I won't say over the counter, but it's almost to that point. Somebody will write a prescription for you. There's some websites you go on that have contracts with physicians or somebody else to prescribe it for you. So there's a variety of recommendations out there. I think right now the pretty much across the board recommendation is to hold it for at least a week, and we're even seeing some patients that it's beneficial to hold it for 2 weeks. Um, my personal take on this is I just go ahead and assume they're probably high risk for aspiration and do an RSI on all of them, no matter how long they hold it. Things that can help you out a little bit, stuff like gastric ultrasound, um, but we'll talk about kind of the issues with that in just a second. These are a lot of the different GLP-1s that are out there. I think semaglutide is probably one of the more common ones we're seeing right now. Either semaglutide or delaglutide. You may be more familiar with them by their brand name, Trulicity, Ozempic, Wegovy, those sorts of things. So a lot of these initially came out as injections, and a fair number of them have now transitioned to an oral form. So just ask how the patient's taking them because that may affect things as well, as far as like duration action and that sort of stuff. Some of these are daily medications, some of these are weekly medications. Um, the ones that are kind of like big right now, like I was talking about, like semaglutide and like delaglutide, people are pretty familiar with. But the others have been around for quite a while, like Byetta and Victoza. You may see this in combination with antihypertensive as well. So look for kind of some of the boutique medications that are coming out, um, and just pay attention to that. So this is kind of what I was talking about. If you've got patients on daily dosing, the official policy is to hold it on the day of the procedure. But I think it's probably a better practice to hold it for a week prior to the procedure, if not two. Just because we're seeing so many of these patients are having aspiration or near aspiration events. Um, Other things to consider for these patients, if this is somebody that is truly diabetic and they're taking it for that reason, you may need to consider putting them on some other sort of bridging therapy, maybe insulin, maybe metformin, because otherwise they may have pretty pronounced rebound hyperglycemia. They can usually talk to their PCP or endocrinologist about that to figure out what the best option is for them. When we bring them into the hospital, obviously we hold the GLPs and transition them to insulin usually. So, day of the procedure, you really need to do a very good assessment of this patient. Look for GI symptoms. Are they nauseated? Are they vomiting? Do they feel bloated? Are they having abdominal pain? If any of those are present, consider talking to the proceduralist or the surgeon and the patient and canceling the case. One of the common scenarios we see these patients present for is endoscopy. So they're getting an EGD or a colon, which is kind of problematic for us because they're not going to have a secure airway during that procedure. So kind of an increased like spidey sense for those patients. If they don't have any symptoms, the agonists have been held as advised. There's really no reason to wait. Some facilities are doing a gastric ultrasound on all these patients. My problem with the gastric ultrasound for these patients is you're literally just looking at the stomach. So there's definitely potential for there to be retained food products other places that can regurge into the stomach with induction. Um, we have some to no evidence as far as timing, so a lot of it has been kind of guesswork and conservative measures. What you'll see is that the anesthesia folks put out literature that suggests you wait a week or 2 weeks. Then you turn around and the GI folks put out evidence that says it doesn't really matter. So there's a whole lot of back and forth for those folks. Gastric ultrasound definitely comes into play. You can use it to evaluate things, but like I said, it's not totally conclusive. Now, obviously, if you take a look at their stomach and there's no contents in there, there's probably a reduced risk of aspiration, but there's nothing to say that their gastric sphincter doesn't open, and next thing you know, that stomach's full of product. So just be cautious with those folks. Any questions about that before we kind of move into preoperative evaluation?
Dr. Cornelius.
I think he might have gotten dropped from the team meeting.
All right, that makes sense.
Hey guys, sorry, I'm not sure what happened there. Where did it cut out?
You stopped right before the pre-op eval. That's when I stopped being able to hear, was right when you started with the pre-op eval on
Okay.
slide 20.
All right.
You asked for questions, and there was a couple in the chat.
And then it was gone. That's good. We'll go back to that then.
Steve kicked you out.
It wasn't me.
That sounds suspicious. It probably was you.
I'm too sick to care about that right now. I do have a question though that's not related to this. Quiz 3, is that going to be on the test, and are you going to post that?
Stand by 1 second. I'm trying to figure out. Quiz 3 will not be on the test, but it will be posted here shortly.
Okay, thank you. And I think Jackson had a question in the chat.
You may see that concentric hypertrophy is the initial presentation, or they had eccentric and it was never diagnosed before they had an echo done, and then it was already concentric by that point. All right, you guys able to see my slides now?
Yes.
Yes.
Okay, cool. For some reason, it wouldn't let me share those either. All right, so we're going to pick back up talking about pre-op evaluation. So big things for us to think about there. Evidence of hypertension, diabetes. So how long have they had diabetes? How long have they had hypertension? What are their normal values? So what's their normal blood pressure? How well controlled are they? What is their normal A1C? From the diabetic standpoint, are they checking their blood sugar? How often are they on oral or subcutaneous medications? Both of those kind of contribute to the severity of the disease. You then have to worry a little bit that they've got heart failure. So now we've added in a concern for fluid overload in these patients, and then hypoventilation syndrome. A concern we really run into, especially in this day and age of laparoscopic or robotic procedures, is oftentimes the positioning contributes to all these factors. So if you take somebody who doesn't do very well breathing and then you stand them on their head and crush their lungs and then insufflate, they can be very difficult to manage from a pulmonary standpoint. So the diabetic component or the blood pressure component may be the easiest part of it. It's certainly contributed to the point they're at with all these other things, but that may be where you truly run into trouble. Things to think about for these folks that kind of make you start thinking they are going to be difficult to mask ventilate or difficult to intubate. If they're on CPAP and they have a PEEP or a continuous pressure higher than 10, they're probably going to be difficult to mask ventilate. So with those folks, a lot of times what I will do is start off. I won't give them anything that causes sedation, so like midazolam, any of those sorts of things. Have them pre-oxygenate for a longer period of time. I may consider having them sit up. You'll see a lot of times they're not able to lie flat without having difficulty breathing. They'll sleep in chairs, stuff like that. So I don't know why we think that it would magically get better under anesthesia. So have them sitting up to pre-oxygenate, minimize the period from when they lay down to when the tube is in. You may also consider, if you are having to mask ventilate them, that you put in an oral airway, sometimes an oral and 2 nasal airways. And then on the back end, oftentimes I'll wake them up with nasal airways in place. That lady I was talking about last night, I went ahead and put in a nasal airway on her while she was asleep just because I assumed she would probably obstruct. If you put it in there with lidocaine and you do it while they're deep, it tends to sit pretty well. So just put some lidocaine jelly on there, put it in a little bit early, and then by the time they're waking up, it doesn't bother them so much. And then she was just happy and pre-op and pulled it out. Things to think about. I mentioned there's kind of an increased incidence of these patients having bariatric surgeries in the past. So see what their current weight is, see what their kind of high weight is before the procedure. The good news is that means they've probably already been intubated, so we can figure out, were they difficult? Did they wake up with a sore throat? Did they wake up and their jaw hurt? Those sorts of things kind of lead us to believe that they were a little bit more challenging to intubate. A problem we run into for these folks is getting IV access just because of the distance between the tissue and the vasculature. They also tend to be in the hospital a little bit more often, so their veins may be scarred up or a little bit more tortuous. The nice thing about that is now we have the ultrasound available to us. The downside is oftentimes we have to get bigger IV catheters. So make sure you know where those are if need be. But I think you guys are, from the ICU side as well as from now, you kind of have started developing the ability to use that ultrasound. So I think that's helpful. Because of the pulmonary complications, oftentimes we wind up having to take these people to the ICU because we can't get them extubated or we're concerned about getting them extubated. So the ICU kind of I don't want to say poo-poos this, but what you'll see is if they have even the slightest bit of anesthetic agent still in their system, that it's hard to get them extubated. And then they get up there and like 2 hours later, they've got them extubated and they're like, why did this patient take an ICU bed? And part of that is because that OR time is more expensive than that ICU time. The other part of it is that it's safer to take them to the unit where they're really being monitored by somebody that knows what's going on, as opposed to taking them to the PACU where you may have multiple patients and they're not quite as tuned up on taking care of sick people. Another concern for these folks, or thing to think about, if they've had surgery before, what was the outcome from it? Why are we taking them to surgery now? Obese patients tend to have an increased incidence of wound infections. You'll see things like Fournier's gangrene is pretty common, as well as just kind of other soft tissue infections. So we usually continue most of their home medications. The ones we want to kind of pay particular attention to are their antihypertensives, their insulins, and their oral hypoglycemics. So if you have somebody that's on insulin, you need to know a little bit about their insulin before you decide what to do with it. Something short term like regular insulin is probably okay to continue. If you have somebody that's on something longer lasting like Lantus, you may need to discontinue it, especially if they usually take it in the morning, because you're going to be battling blood sugars all day. Now, the caveat to that is if you discontinue it, you probably need to pay close attention to their finger stick, and you may need to give them something short acting like regular to kind of counteract it. Same thing with the oral hypoglycemic because that's what's controlling their blood sugar. So if you take it away, you need to step in to manage it. Almost all these patients are going to get antibiotics. A caution for you, most of our antibiotics are weight-based. So usually if you get over 100 or sometimes 120 kilograms, we have to add like a third gram of Ancef or something like that. So know what the practice is at your facility. Most of them have like an antibiotic nomogram that tells you exactly what to get. As we talked about earlier, they're at increased risk for DVTs, so mechanical as well as pharmacoprophylaxis is certainly encouraged for these patients. And then same thing as far as like aspiration prophylaxis. Think about what you're going to do that may help reduce the risk of aspiration. So a couple different things we see that go on in their airways. There's a decrease in a lot of their different values. So vital capacity goes down, their inspiratory capacity goes down, their ERV goes down, and their FRC goes down. So that's kind of something helpful for you to remember when you start studying, that most of those capacities are going to go down. Their compliance tends to be very poor. Their closing capacity is close to or usually within like tidal breathing. So as a result of that, a lot of times you'll see that you get very limited air exchange in these patients, especially if they've been laid down. So why does that matter to us? They tend to desaturate very rapidly. So pre-oxygenation is definitely your friend, especially when you're starting to learn. So a lot of times what I'll do is bring these folks into the OR, go ahead and throw them on the oxygen so they can start saturating when I first get in there. I usually will get a baseline SpO2 from pre-op, so I don't have to worry about that. But if you can't do that, I would make sure you get that before you put any oxygen on. That way you kind of know what you're working with, because on the back end, if their baseline O2 sats like 91, 92, they're probably not going to get up to 100 during the emergence phase of your case. So just be careful with that. So that's kind of some things to think about from the preoperative standpoint. Now we're going to talk a little bit about intraoperative stuff. So big things for us to think about. Positioning is obviously a huge concern. We've talked about that several times already. So how do we position these patients? We're going to go into great detail here in just a second. Part of it just depends on what procedure we're doing. Airway management can be problematic for us because they do tend to be a little bit more difficult. Even something as simple as monitoring can be difficult. Where am I going to put the leads that I get the best EKG tracing? Do I have a long enough arterial catheter to get in there because they have like big wrist or they have a big groin? From an anesthetic standpoint, what can I do to optimize their emergence and reduce their postoperative risk? And at the same time, keep them appropriately anesthetized as well as keep their pain under control. And then fluids management can be problematic as well because they tend to have a little touch of heart failure. Lots of times they're prone to peripheral edema. All those sorts of things can be difficult for us. So we're going to talk a little bit about a kind of positioning and look at some examples here. So from a supine position, one of the biggest issues we run into is ventilatory impairment. The aorta as well as the IVC are both compressed. The diaphragm is compressed by the abdominal girth. We've seen multiple reports in significantly obese people of having rhabdo from just laying on their gluteal muscles for long periods of time. So there's not a whole lot we can do. We can do, additional padding and stuff like that. But really our biggest goal is to try and get these people out of the operating room as soon as possible. Not that we hang out there for long periods of time for our health, but probably don't want to keep them there any longer than you have to. When we turn them prone, uh, because of the way the prone beds are set up, you'll see that a lot of times the pads that are there to support them will have excess pressure. So the parts of the body that those are touching may have increased risk of rhabdo. And the other thing is you've got to make sure that they're well placed and that there's enough of them. I'll show you some pictures here in just a second with like some of the spine tables that you may see that the abdomen, which is already rather large, becomes kind of pendulous, so it's kind of falling down through that. So you have to make sure those pads and those positioners are well placed so they don't slide or fall. If you turn them lateral, they tend to have increased incidence of dependent pressure ulcers. So whatever's on the downside is probably a little bit more at risk of having tissue breakdown. We encourage everyone to put axillary rolls in these patients, but what you'll see is a lot of times traditional axillary rolls and even kind of hyped up ones are just absorbed by the patient, so you can't even tell it was ever there. Now, when you start thinking about patient positioning, there's lots of different ways we can do cases. If you have a choice in these patients, it may be better off to turn them lateral as opposed to turning them all the way prone. And sometimes we'll do like a sloppy lateral, especially since there's kind of an increased incidence of lower extremity INDs and those sorts of things in these patients, where we'll just turn their back a little bit and then we turn their legs all the way. So they're not in a true prone or lateral position. It's kind of a hybrid of the two. And then lithotomy things to consider. The regular stirrups may not be enough to hold their legs up, so you may have to get kind of the supersized stirrups, especially if you're using something like candy canes. May not be a good idea for these patients because they will have compression. And one of the things you really have to worry about with these patients with the compression is that there's an increased risk of compartment syndrome. So this is kind of our first example of positioning. So when you take a look at this, what strikes you guys? What's kind of concerning when you look at this patient? So think about how he's positioned. So he's turned on his, so airway's concerning. Um, as we move these patients around, we obviously worry about our tube migrating. Other things, let's look at that up arm. You see how there's kind of increased pressure there, which probably right around his elbow. You'll see that we have to worry a lot about nervous injuries in these patients because they have like extra pressure there. So that's a concern. What about this strap down here across his hip? Do you think that's going to be adequate to control him if he starts to slide off that bed? Probably not. So another thing we do is a lot of times we'll have one strap on a normal patient. For some of these larger patients, you may want to go ahead and put a second strap on there. Now, where do you put that second strap? Part of it depends on the surgical procedure. So like this guy has one across his low hips and then his arms are secured. I can assume we're doing something like a nephrectomy or VATS. Maybe you can take an additional strap and put it up closer to his axilla, and that may be out of the way to the surgical field. Or maybe you can put an additional strap down on his legs, and that would help out. The other thing you see, because obese patients are so large, some facilities aren't truly equipped to handle them. So there's kind of makeup of positioning aids. So you'll see things like tape and Coband is often used in place of the things we should really use for folks. So this is kind of a worst case example, but there's a lot of things that you can see that are going on here. One, you can see truly how large these patients are. I assume this facility did not have straps large enough to hold the patient in place. So they're in kind of a low lithotomy position. What do you think about that hip positioning? Should we have our legs at different positions like that? That's probably not great for them, right? So you have to worry a little bit about how rotated that patient is. And one of the weird things is if you look, her left hip appears to be higher, but her leg is actually lower than on the right side. So that's probably not good. Looks like we've used kind of a large co-band strap or an A strap to hold them in place. Probably not good either. Um, you can see how vascular access might have been difficult in this patient given her large arms. Um, so lots of different things going on here. And then you really feel sorry for whoever the nurse was that put the Foley in. So this is what I was talking about as far as like prone positioning. This is the Jackson frame. So you see those pads there. This guy's obviously not on those pads very well at all. You see how they've had to pad along that rail because that's truly where his body is sitting. So that's not a great setup for him, right? As I mentioned, you can kind of see that pendulous abdomen hanging down between the frame. So this pad that's right in the middle of your screen should really be a little bit lower down underneath the patient on kind of a bony prominence, because in this setting, it's not doing much. The pads on his lower extremities look like they're in pretty good position, and good props to them that they did pad along that rail, but you can see as you get a little closer up to his chest here, he's still kind of in contact with that. So when you start thinking about how pressure is applied, if you apply pressure over large surfaces or flat surfaces, it's definitely better than kind of things like the edge of a rail. What about looking at his elbows there? What do you guys think about that? Where's all the pressure?
On
So
the
the good
like
news,
forearm, the elbow.
yeah, exactly. So the good news is most of it looks like it's on his forearm. The big area we kind of worry about as far as like pressure on nerves is right there at that ulnar prominence. So it looks like that's probably free. So maybe that's okay. The downside is his blood pressure cuff has slid down and it's almost over top of it. So that may be problematic for him. Maybe this patient would be better off having an arterial line in place. Not sure. So just different things for you to think about. Now here's a much larger patient in kind of a similar position. So what are this patient's feet on? Can you guys see that? If you can't see it, they're on like a Mayo stand or like a surgical table down there. Um, Probably not good. Uh, so why are we in this situation? So if you look, most of our beds have the ability to kind of slide. So this bed has been slid almost all the way down to the feet. How stable do you think this table is with this patient who's obviously quite large, their whole body weight kind of free hanging there over the other end? Not real stable. So what they've done to kind of support that is bring in this table and put that under the patient's feet. If the patient falls or there any sort of bad outcome, the manufacturer of the table is not going to support you in this instance. So the reason I put this picture on here is all of our OR tables have different weights they will tolerate, but they also have different weights they will tolerate in different positions. So if you look at this pedestal that's right underneath the patient's head, that's the part that goes from the table to the floor. It's all the way extended. The pedestal is really designed to be centered underneath the table because that provides the best support for it. You have the ability to slide one way or the other. Oftentimes we'll do that to do things like bringing a C-arm in, but this is not what the manufacturer intended. And I'm pretty sure if you go through and check and see what the pedestal weight is with it all the way shifted over, they're out of compliance. So things to think about as far as airway assessment. Um, it's kind of a catch-22. We plan for the worst, but you will often see that even though these patients are anticipated to be very difficult, that they're not. They may be just big on the outside, not big on the inside. But it is also fairly common to see extra adipose tissue deposited into most of your airway structures. The other thing you'll see is that the oropharynx will transition from kind of being round to being almost elliptical. And you'll see that as the degree of obesity goes up, the monopharyngeal area goes down. So all those things kind of make sense, but they also all contribute to us having a little more trouble getting them intubated. So predictors of difficult intubation, BMI itself may not be the only predictor. So actually make sure you go look at their airway, see what their mouth opening is, look at their dental structures. Do they have like big upper incisors that are going to be problematic for us? Do they have a significant overbite or do they have like a retrognathia? How much mobility do they have in their neck? Even though the osteoarthritis I mentioned tends to be due to like walking around and wear on joints, you may see that it also extends into their necks and things like that. So this is probably the most common position you'll see for getting these folks intubated. So what we kind of do is get them in this ramped position. Now, how you do it really depends on your facility. But what we're trying to do is somehow elevate their head as well as their shoulders. And that's one of the issues we run into. Oftentimes people think about just putting the head up, but they neglect the shoulder part of it. Some places have this pillow like you see on the right. It's called a troop pillow that you can kind of put the patient up on. The nice thing about that is that it's one piece. It's easy to remove. The downside is depending on the surgery, you're probably going to have to pull it out because they can't work with them in kind of this elevated position. But that applies for most of these devices. Over here on the left, you kind of see a before and after shot. So this lady was laying supine. You can imagine how difficult it would have been to get her intubated. And then you can also see, especially with like her large abdomen and large breast, that both of those are going to be pushing on her lung. So it's going to be kind of hard to ventilate her. And then we've gone through and put a whole lot of positioning aids under her. What are those? Anybody tell me what those look like? It's like every blanket and sheet they could find anywhere. So some facilities have a lot available to you, some do not. Some places they get really mad if you take like 20 blankets and sheets and use them to position the patient, because after that they're going in the laundry, so that's like 20 less blankets they have. So if you have the option, something like this troop pillow may be nice. The other thing that's out there, I'm sure you guys have seen like the hover mats that you can inflate and kind of move patients over. They also make inflatable airway pillows. So the nice thing is that you can inflate it when the patient moves over onto it, and then you can deflate it for the surgical procedure, and then you can inflate it again to extubate them. If you don't have those options, you can also consider leaving them on the stretcher or the bed to intubate them, because it's pretty easy to sit them up and then move them over to the OR table after they're already intubated and you have control of their airway and ventilation. Just a refresher on all the axes. So you can see how, like I was saying, it's important not only to do the head tilt chin lift, but also to elevate the head and the shoulders to get them in good alignment. If you go into these airways and anticipate it's probably going to be difficult, you'll do pretty well getting them intubated most of the time. Now, with that being said, as a caution, you probably want to make sure you've got your backup airways available. So things like, bringing the glide scope into the room, it's like your comfort blanket. It's there. If you have it, you won't need it. But you'll see that you can usually DL these people pretty easily. It's just kind of scary until you do it a couple of times. So things to think about from like a research standpoint, it's pretty obvious if we position our patients well, they will be easier to intubate. Where we get into trouble is when we either get lazy or get rushed and we don't have a chance to see the patient, or if we do have a chance to see the patient, that we don't get them well positioned and think we can kind of get through it. With time and experience, you will be able to kind of muscle through those airways, but especially when you guys are first learning, it is very difficult to stumble through it, kind of not even a difficult airway, but just a little bit of a challenging airway without good positioning. Other things that we realize, most of our obese patients will desaturate twice as fast as non-obese patients. So if you do a good job pre-oxygenating somebody, the research says 5 to 6 minutes, but I've seen them go as long as 10 minutes without desaturating, and that's without being ventilated at all. Those obese patients are probably going to be half that, if not less. I've seen obese patients, especially sickly ones, that you did everything you possibly could, and they still desaturate in 30 seconds. So things we can do to kind of help out. This is during the maintenance phase of our case. For the most part, but how do we pre-oxygenate these people? So a little bit of CPAP will help you out. So sometimes what we'll do is just turn that APL valve to like 20 to, or excuse me, like 10, put a little bit of pressure on it. You can also put them on PSV with a little bit of PEEP or CPAP if it's available on your machine. So part of it's just knowing what's going on with your machine. Other things to think about, like I was talking, go ahead and sit them up if you can. So either on the stretcher, sometimes you can put them in reverse T-Berg. The problem with reverse T-berg is they tend to slide away from us. So sometimes what I would do is put the legs up and put them in reverse T-berg so they're almost like folded up a little bit. Or if you have one of the headpieces you can put on the bottom to bring it up to 90 degrees so their feet are against that. That helps them not slide down as well. Other things to consider, what sort of PEEP do you need to maintain this patient on? Most of our patients we maintain on at least 5. These folks may need a little bit higher, especially as we get a little bit further into the case. Commonly what you'll see is their saturations hang a little bit low. You go through and get them recruited. And then if you don't increase the PEEP, that a lot of times they'll kind of slowly trend down again. And then get them on the ventilator as quickly as possible after induction. Even though we think we do a great job hand ventilating patients, the ventilator does a much better job than we can. So aspiration, I touched on this earlier, but we're going to kind of revisit it again because it's a huge problem we run into. So what can we do for these folks? One, figure out that they're high risk. So obesity alone may be enough to make us think about them being high risk for aspiration, but think about obesity in the setting of trauma or any sort of disease process. We know that all of those are going to impair gastric emptying. So when you see those things happening, anticipate that there's an increased risk for aspiration. So what do we do after that? Prophylaxis and multiple prophylactic agents. So this is somebody you probably want to give Pepcid to in pre-op. As I mentioned, metoclopramide may be beneficial. Things like Zofran and Decadron are obviously important. And then, as I was saying, if they're high risk, I'll go ahead and do something like Bicitra. Other things to think of on the kind of the intraoperative part of this, what sort of medications do we give that delay gastric emptying? Anybody know what like one of the biggest ones is that we use? Bueller.
Reglan.
No, Reglan promotes gastric emptying. Yeah, Laura got it. Opioids. So one of the problems we run into is if we give these patients large amounts of opioids, especially long-lasting ones, that it tends to impair gastric emptying. So we may decrease our opioid use for that reason. The other things is opioids tend to cause hypoventilation. They tend to cause sedation. So we may consider pain medications that do not do all those things. This lady I was telling you about last night, on top of all her other issues, she was also allergic to fentanyl. So we didn't give her any fentanyl. We gave her Toradol, we gave her Tylenol, we gave her magnesium, we gave her ketamine. She was on norepinephrine, so I held off on giving her any Precedex because that would kind of kick myself in the butt. But she woke up totally pain-free after a huge debridement. So things like that may be an option for you. And this is when we really kind of have to start steering away from the what we always do. So just keep that in mind. Regional is totally safe in obese patients, but it can be very challenging. One of the biggest reasons is just finding landmarks. So if you look at this picture, you know, they've picked a spot there, but can anybody look and see any spinous processes? I sure can't. So things that may come into play for you with these patients, being able to use the ultrasound to identify spinous processes, but you may need longer needles. You may have to use different ultrasound probes. We commonly use linear probes for almost all of our regional procedures. This person may be so big that you have to get a curved probe. Another thing you see, which seems kind of counterintuitive, because they have increased body habitus, there's more pressure on the epidural space, so it tends to be a little bit smaller. So you may see that you actually want to decrease the volume you administer to your epidurals, so you don't wind up with a high block. There is an increased incidence of block failure. Part of that is just due to like blind technique. So if you're putting an epidural in somebody, it's a little harder to feel if they've got, you know, no landmarks and increased tissue. The other thing you'll see is after you do something like a spinal or an epidural, they have an increased risk of IVC or aortic compression because there's more body habitus sitting there. So again, increased risk of hypotension. Now, not to sound crude, but what are all the patients, almost all the patients we're putting epidurals in? They're all artificially obese, right? Because they've got this weight gain, they've got this huge bowling ball sitting in their abdomen. So all of those patients may temporarily experience some of these things, or they may have underlying obesity to add to it. Other things to consider for these patients, make sure you've got the right size blood pressure cuff. We're really bad about just moving blood pressure cuffs around to where they fit. We're probably not going to get accurate measurements in those patients. So make sure you're actually looking at the size of the cuff. The bladder itself needs to go around at least 3/4 of their arm. Most of them have marks on them, but make sure you have like the large or extra large blood pressure cuffs available to you. As far as like other monitoring devices, a lot of it really depends on what comorbidities we're dealing with. If you've got somebody with pulmonary hypertension, especially bad pulmonary hypertension, you may need a PA catheter, but I think TE is more common for these folks. We may have a hard time getting IVs in them, so we may have to go to a central line. We talked about them being at increased risk of DVT and PE. So if you have somebody with significant injuries or somebody that's going to be in the hospital for a while and not real active or not real active anyways, we may put an IVC filter in them prophylactically so they don't wind up showering clots. If we can't get accurate measurements with a non-invasive blood pressure device, we may quickly go to an arterial line. Also adding to that is that we're concerned about pulmonary complications in a lot of these patients, so that way we can get lab values, we can get ABGs, those sorts of things. As far as the medications, there's really not any perfect plan. Um, some people encourage Tivas, some people encourage regional, spinals, epidurals, generals, gases. There's kind of benefits and downfalls to each of those. Just some kind of specific things we're going to talk about. You tend to see exaggerated responses in a lot of your sedatives in patients, especially with sleep apnea. So like opioids, propofol, benzos, a lot of those will last longer and have more significant effects. So you gave the same 100 micrograms of fentanyl you give to every patient, but now this patient doesn't want to breathe, doesn't want to wake up, those sorts of things. Dexmedetomidine can be very beneficial for you, but it can also be problematic. So if you're using it in lieu of giving opioids, it may be a nice option for you. But one of the problems we run into, in addition to the analgesic capabilities, is that you tend to get a little bit of sedation. So it may not be a good choice for you from that standpoint. The pharyngeal muscles tend to be very weak, especially after administration of neuromuscular blockers. So commonly on these patients, we will make sure we reverse them with something like Zagamedex as opposed to neostigmine and glycopyrrolate. There's an increased incidence of airway loss or decreased airway patency because of the redundant tissue there. Other things to think about from like a volatile standpoint. In a perfect world, what would we use as our volatile for these patients? Come on, what do you guys think? So if I was going to give them a volatile agent, which one would I want to give because it goes away very quickly and it comes out of that tissue very fast so they wake up better?
SIBO.
Nope. Desflurane. There we go. If you go to a lot of bariatric centers, they will still use desflurane for a good number of obese patients because it does go away very quickly. There's certainly drawbacks to it. You know, coughing's one of them. Environmental damage is another. Cost is another. But desflurane is your drug of choice as far as volatiles for extremely obese patients because it will go away quickly, so you don't have to worry about the respiratory depression and kind of the prolonged loss of muscle tone from your volatile agents. SIBO is kind of middle of the road, and then ISO is your third choice for that. A lot of times we won't use nitrous in these patients just because they tend to require a little bit of extra oxygen, and that can be problematic for us. So these are just some examples of things you base on ideal body weight versus total body weight. And I know there are other sources out there that have different answers, but just something for you to kind of think about here. The other thing is you can always give them more of a medication. So if you give them 100 a probe because that's what they've, theoretically need, and they're still wide awake talking to you, it's really easy to give more. On the other hand, you give them 100 a probe and they're hypotensive and apneic, then it's kind of hard to make it magically go away. So things to kind of consider as far as based off ideal body weight, probe, RIMI infusions, and then most of your neuromuscular blocking agents. based off of total body weight. Some of your other opioids, fentanyl, sufenta, sucks, cisatracurium, and midazolam. But a caution, like I mentioned earlier, be careful about giving really obese patients heavy sedatives. So these are people I won't give midazolam if I don't really need to. And then we talked about like the volatile agents. The DES is probably the preferred one. So other things to think about as far as like positioning of these patients. One, make sure it's appropriate for the OR table as far as their weight. Most of the time, if you need to, you can change it out for a different table. Other things that can be an issue, safety straps. As I mentioned, always make sure you've got a couple of them on there. And then how do we get them over here? One of the issues we run into if you don't have like the little hover mattresses is they're hard to move. They're big. And then what are they going to lay on when they get over there? So if you're turning them lateral, you have to be really cautious about what's underneath them because of that increased body habitus. There's a lot more pressure. So like an IV cap gets stuck under them, or even something as simple as there's a sheet underneath of them that's got a fold or a wrinkle in it. That can be enough to cause tissue trauma as well. And then a big issue we run into these folks is how do we keep them warm? They tend to lose body temperature faster because they have more surface area than some of their skinnier counterparts. So pre-warming may be beneficial, and then keeping them warm during the perioperative period as well. Other things to think about, what do we do with their extremities? So some of our beds will have like bariatric expanders. So instead of just clipping the arm board to the rail, there will be like a second rectangular structure that clips onto the rail in a couple of different places, and then you put your arm board on that. But what if we need to tuck the arms? Sometimes tucking the arms doesn't work because they just overhang the bed by that much. I've seen more than one time it almost looked like the surgeon needed to be suspended by a crane and lowered into the abdomen because they just couldn't reach from the side of the patient. So sometimes you may not tuck arms for a procedure you normally would to get those arms out of the way. These sleds, which is what this clear plastic thing is, sometimes they work for you, sometimes they don't. The whole way they work is just being tucked under the bed. So if the arm sticks so far off the side of the bed, you may not be able to use those to secure the patient. Other things to think about, fluid requirements. Commonly, because that increased volume distribution, we wind up having to give them more fluid than you would for a normal patient. Other things to consider, how are we monitoring their volume status? Are we just looking at Foley? Do we have like an ultrasound on the IV? Are we looking at a flow track? All those sorts of things are kind of good thoughts for you. So on the back end, how do we get this person extubated into PACU? As I was saying before, sit them up, make it a little bit easier on their lungs. Full neuromuscular blockade reversal. So Gammadex is your drug of choice here. I will oftentimes overshoot and dose this on total body weight, even though it's not necessary. But in my mind, it makes a lot more sense to have them over-reversed, as you will, as opposed to under-reversed. Some people will use pressure support for these folks. Some people use SIMV. I really feel like pressure support is beneficial, and then getting them back breathing earlier and letting them breathe spontaneously longer may be a little bit easier. The trade-off for that is you now have somebody breathing spontaneously through a soda straw. So that may increase their work of breathing and they may not fly. A lot of times as you get to the point of kind of extubation for these folks, it's a little bit of a guessing game to figure out if they're not breathing well because they can't breathe through that tube, or is it that they're just not breathing well. Continue them on their home levels of CPAP. Oftentimes, if we have somebody that's on CPAP or BiPAP, we will ask them to bring it to the hospital with them, and then we will put them on their own device and PACU. The trade-off for that is if they don't have anybody to set up the device for them, that respiratory may not be familiar with it, so they may just put them on one of our devices. To give them opioids or not give them opioids is always kind of a question. Personally, if I'm concerned, I will withhold or decrease my opioid dosage till they really demonstrate it. I'm still going to give them stuff for pain, but I may not give them stuff that causes respiratory depression. Something else for you to think about with these folks, consider when and where these cases are done. So without fail, it's going to be like 3 a.m. in a broom closet somewhere. That's the worst scenario. Complicated patients should not be done after hours and in off-site locations if you can help it. They're higher risk. They tend to require more devices and more support. So try and do them in the main operating room. Try and make sure it's during normal hours so you have all your friends around. Obviously, if it's, an emergent case, we don't have control over that, but those are definitely things I would consider. And there's some other reading for you.